cardiac arrest and CBD, bystander CPR, what is instant survival, resuscitation education, high quality CPR, strategies to increase AED usage, what are the predictors of survival of out of hospital cardiac arrest, resuscitation systems of care, post-cardiac arrest syndrome, and the role of cardiac cath lab in OHCA management, prognostication of OHCA, COVID and out of hospital cardiac arrest, what is the need to address OHCA in India. Out of hospital cardiac arrest is the loss of functional cardiac mechanical activity associated with an absence of systemic circulation occurring outside of a hospital setting. The survival globally is on average less than 10%. Despite the best systems also, survival is very poor. In the best systems, in an optimum management, it increases to 20% and sometimes 40 to 50%. There is variation in survival outcomes worldwide. The most common cause of OHCA is acute myocardial infarction, and the other causes like cardiomyopathy, and there can be non-cardiac causes like asphyxia and respiratory causes, pulmonary embolism, and other things. The ICSIN guidelines, they form the framework for management of OHCA, and they form the basis for OHCA registries. They are the consensus reporting guidelines for resuscitation, and originated first time from Norway in a place called ICSIN Abbey, and they are the foundation for clinical research, and they provide a structured framework to compare the different systems of cardiac care, and they provide an epidemiology of cardiac arrest and the driver for quality improvement in OHCA management, and they identify gaps in management. The ICSIN elements like system factors, patient factors, process factors, dispatch factors, and event factors, they are the ones which the core elements and supplemental elements which determine the basis for OHCA registries. Like there are various registries throughout the world. The resuscitation outcome, European registry, the Pan-Asian throughout the world like Japan, Denmark, and other things. Registries in India are very less, and we did the first registry on OHCA from India, that is the Varangal area out of hospital cardiac registry, which is the first one in the country, and it is a regional and local registry. The other studies which we submitted in the Mexico was not based on history template, but and we did from the media reports, we did an observation study on out of hospital cardiac. What is the basis for chain of survival? What is the basis for OHCA? The early recognition of cardiac arrest, early application of bystander CPR, early AED application, early arrival of AMS, the early treatment post-cardiac arrest care, they determine the fully recovered neurologically intact subject of OHCA, so that all these links should be improved in OHCA management. And first thing in a country like India is community awareness, where we have to create community awareness on cardiac arrest through various resources, conducting World Heart Day, Tobacco Day, and other Diabetes Day and Hypertension Day. What is bystander CPR? It is performed by a person who is not responding as part of an organized emergency system. Even doctors, nursing staff, medical personnel who do not form part of the EMS or an organized response are known to perform bystander CPR. Worldwide, only 40% of subjects receive bystander CPR, whereas the AHA has recommended 62%. In India, it is very dismal. Only 1.3 to 8% receive bystander CPR. Bystander CPR training is only 40% throughout the world. The Heart Rescue Project of North Carolina exemplified the importance of community awareness of CPR. What is instant survival? Those subjects who receive bystander CPR, the survival is very good because it's a witness cardiac arrest and they have an initial rhythm of shockable rhythm, a pulseless VT or VF, and this is called an instant survival. And this is a measurement tool to know the effectiveness of community CPR training. Resuscitation education guidelines say that a 30-minute CPR training is better than a long CPR training course, and the current recommendation is not just attending the course. We have to focus on learner outcomes, which I am going to tell. So school-based training, targeted CPR training for families, and social media applications are the modalities of resuscitation education enunciated by the American Heart Association. Now, a word about high quality CPR. When you ask someone whether they perform bystander CPR, yes or no, it is a binary variable. But what is important is only high quality CPR will impact the outcomes in a OHCA subject, Hence, the quality of CPR is very important. Now, in this, what is the high quality CPR? Performing 100 to 120 times, at least 2 inches in depth, without any interruption, without any excessive ventilation, is called as high quality CPR. And in high quality CPR, the term is important is chest compression fraction, CCF. It should be above 80%. The chest compression fraction is the amount of time during a cardiac arrest event that high quality chest compressions are performed. So, if the CCF is above 80%, the chance of survival are 200 to 300%. And if the CCF is less than 80%, the survival is poor. Now, for a minute I demonstrate. Now, the latest, earlier we used to train bystander CPR using the ladle mannequin, but the latest guideline by AH and international guidelines say that we have to train them in only high quality CPR, giving feedback. This is the mannequin which contains a gadget. We have to place it on mobile. It works through a mobile app, QCPR app, which both Android and iPhone have it. Then we have to place it, connect it through the mannequin through Bluetooth. Then we have to place on the joint, we have to train. Now, as you know, here it gives the compression depth, the compression recoil, whether it is correct or not. Even the rate of compression will be measured, known in this. Now, when we are training a person, here you can see that beside that in the iPad or iPhone, using the QCPR app, we are monitoring and it will give a feedback whether doing it correctly or not. And this will give a score, that is a 95, and it will give feedback also where he is going wrong. This is, for example, before training the score is 42%, after training the school student it is 92%. So, European formula of survival says that combining medical efficiency, medical side with educational efficiency and implementing it locally, we can train community CPR training, and European formula of survival is the basis for community CPR training. Manual versus mechanical CPR. You know, mechanical CPR is not associated with improved return of spontaneous circulation. It only improves the quality of CPR. Suppose if someone is fatigued, you can use a mechanical CPR. It's not used on a regular basis. Only in COVID situation they have used mechanical CPR. And during transportation times to the hospital also we can use a mechanical CPR. Now, after bystander CPR, AED application. AED application elsewhere in the world, in all public places, because the commonest place where the cardiac arrest occurs is in a residential apartment. So, residential apartments, condominiums, all these high buildings, we need to have AEDs. In the public places, it is 20%. 80% in residential, 20% in public places. There we need to have the installation of AEDs, and elsewhere in the world, railway station, airport, malls, public places, libraries, apart from hospitals, their AEDs are installed, and it works with a voice prompt. This is an AED in our Hyderabad Rajiv Gandhi Airport in one of the gates. CPR, if we perform it within 4 to 5 minutes, the survival rate will be very high. For every 1 minute of delay, the survival will be reduced by 10%. Similarly with the AED also. So, public access defibrillation we need to improve. This is the demonstration of a training of an AED, where it works with voice prompts. Only thing is we have to place it, and this one. This is an AED training which we use. This is a American Red Cross one. No. So, after doing bystander CPR, and if AED is available, or then if there is a return of spontaneous circulation. What is ROSC? It is defined as if we attain a rhythm which restores a spontaneous perfusing rhythm, and which will result in occasional gasp or a fleeting palpitator pulse or an arterial waveform, as we see in the movies only in our country, then it is called as return of spontaneous circulation. A resuscitation event is deemed to have ended when death is declared or spontaneous circulation restored for 20 minutes. Now, one of the audience asked me recently in one of the meetings, how long will you perform CPR? Lay public, usually as per standards, 30 minutes. But even up to 60 minutes, there are reports, particularly from the Japanese, where performing bystander CPR up to 60 minutes also, the survival is good. What are the predictors of survival of OHCA? The dispatch, the system factors, how early the ambulance arrives, dispatch factors, dispatcher assisted CPR, what we call as telecommunicator CPR, and the system factors, whether the post-cardiac arrest care is correct or not, how early the EMS arrives. Usually the EMS because beyond 10 minutes the survival is very poor. Then the therapeutic factors, what treatment to give. So disparities in bystander CPR, disparities in AED application, disparities in EMS arrival, disparities in post-cardiac arrest care contribute to OHCA survival. And so we need to address all of them. So those where there is old age, unwitnessed cardiac arrest and lack of bystander CPR, where AED is not used, where return of spontaneous circulation is after 30 minutes, and in the initial non-shockable rhythm, the survival is poor. Now, the AHS has enunciated what is called the resuscitation systems of care. One is the resuscitation referral center, the resuscitation centers, and level 1 center and level 2 center. Resuscitation referral hospital is just they manage the patient, they see that the return of spontaneous circulation is there, then they refer to the higher center, tertiary, that is the resuscitation main center. Level 1 center is the initial one, and level 2 should be the level 1 is the tertiary one, and level 2 is the one which initially receives the subject from EMS and do that. Now these are called as the cardiac arrest centers. So my take home message from this is one of the things is we need to establish more and more cardiac arrest centers and resuscitation systems of care in our country. These cardiac arrest centers have a 24 hours availability and specialist care, intensivist care, there is a target temperature management, and the multimodal prognostication is possible. Ultimately, rehabilitation and fully recovered subject of OHCA. Now, what is a post-cardiac arrest syndrome? Because of the hypoxic ischemic reperfusion injury, a complex situation occurs where multiple organs are affected, and in them, the ABCDF, once bystander CPR is done, AED application is done, there is a return of spontaneous circulation, either conscious subject or an unconscious subject. Then they need to be shifted to the cardiac arrest center. Then ABCDF approach, airway, breathing, circulation, neurological disability, clinical examination, and further care. So a multimodal approach where is very important in management of OHCA subject, and the management considerations include the cardiac management using a cath management, pharmacological management, ventilation, and hemodynamic management. What is the role of cardiac cath lab in OHCA? Now, incidentally, whenever someone has a cardiac arrest in our country, particularly VIPs, the media says immediately they will go to ECMO and ECMO management. So the reason for presenting this update is cardiac arrest management, OHCA management is a team approach where even the first one, small things like bystander CPR, AED application will impact the survival. A dynamic decision making method based on situational awareness and assessment of all important clinical parameters is important in cardiac cath lab. It is not just doing a coronary angiography. Other things like PCI, right heart cath, mechanical circulatory support impact the role of cardiac cath lab, and definite or defer activation. For example, if someone has an ST elevation MI, go for early cath. If there is a non-ST elevation MI, if there is a non-perfusing rhythm or a non-shockable rhythm, which is because of non-cardiac causes, then you can go to the, you can defer the management of cardiac cath lab usage. This is about the statistics about commonly LAD is the commonest lesion artery which is involved in OHCA, and in refractory, so the current guidelines say that definite activation in ST elevation MI and defer the management in non-ST elevation MI, non-shockable rhythm. Another 3 minutes. Refractory VT, where the rhythm 3 shocks, despite giving 3 shocks, if there is no survival, then if you don't attend, it is a refractory VT. Or so in such conditions, a hyperinvasive care is very important, where the survival in OHCA is improved using hyperinvasive care, and which limits the utilization of ECMO. Mechanical circulatory support. What are the guidelines say? There is insufficient evidence regarding routine use of eCPR. It can be considered as a rescue therapy in selected patients. The objectives are to improve organ perfusion, and in such conditions, automatic mechanical compression is used. There is no RCTs as far as eCPR is concerned, only observational studies. This will improve, the goals are, it will normalize the perfusion, allow time to identify and treat severe coronary disease. Now, how do you prognosticate? Now, most of the time, the common situation in our country is when someone has a cardiac arrest and comatose, then the attendants are likely to ask, when is our subject likely to, when is our mom or dad going to recover or brother going to recover? If we have to answer this, so answer the family members, we need to have a proper neuroprognostication. This will also avoid futile treatments. when to withdraw life-sustaining therapy, what we call as WLST. So in this, the cerebral, when someone has a good bystander CPR, AED or no AED, and ROSC is attained, a cerebral performance category of CPC 1 and 2 will determine the neuroprognosis, very good recovery patient. What is the neuroprognosis? The goal is to provide information to families and decision making in continuing the care. Post-anoxic brain injury will lead to severe neurological damage. Common cause for death in OHCA is a severe neurological damage. The other causes like shock and multi-organ failure are a limited percentage of subjects. Neuroprognostication usually performed 72 hours after ROSC, and what does this neuroprognostication constitute? It constitutes the clinical examination like bilateral absence of the pupillary reflex and corneal reflex. Next, the biomarkers like neuron-specific enlace, which are not used commonly. Then the EEG, neuroimaging and electroencephalography. These are the constitutes. The word about OHCA and COVID. During COVID, it has disrupted the systems of care of out-of-hospital cardiac arrest management. The survival rate from OHCA was very poor, and even the EMS arrival was very late. So majority of the OHCAs occurred in the residential apartments and homes during COVID time. And in India, there are anecdotal reports of OHCA systems of care which were very poor during the COVID time. Now, lastly, how do you address the COVID in the out-of-hospital cardiac arrest in India? With 25% of mortality due to cardiovascular disease in India, 80% of cardiovascular deaths are due to ischemic heart disease and stroke. 2/3 of NCD mortality is due to CVD related conditions, and with the UN goal already it's quite approaching fast, and the sustainable goals of 2030, UN goal of reducing, the UN goal of 25 by 25 is reducing premature mortality from non-communicable disease in general and cardiovascular disease in particular by 25% by 2025. So there need to be a multi-pronged approach. This is the National CPR Challenge, which I started in 2018 to increase the awareness on cardiac arrest, OHCA particularly, and bystander CPR throughout the country through the NICE program, National Initiative of CPR Education in different Indian languages, including Hindi, Telugu, Malayalam, Kannada, Malayalam, along with one of our colleagues in here, Dr. Vemuri Murthy, that the OHCA pamphlets are published, and this is the NICE program. The different programs. Now, how do you target community CPR? School students, government officers, journalists, court buildings, temple staff, church, public gardens, police staff, NCC cadets, NSS cadets, and this is one of the programs which I did from the Indian Army in Srinagar, and cyclists and walkers and physiotherapists, and we did a mass CPR program in 2012, which got the Limca report. On a single day we trained 4,000 people. Then in other parts of the country, Bombay, Tirupati, in surrounding districts of erstwhile AP and Telangana, we did CPR program. And I'm happy to tell that 2 states have started statewide CPR program. One is the Orissa government, which was started recently, and even the Telangana government. This is, I'm talking about the latest CPR program, Orissa, and which was inaugurated by the CM. So the goals of OHCA systems of care in India, we need to have a national OHCA registry, like in lines of the WACA registry. We need to increase the awareness on cardiovascular disease, enhance bystander CPR, deploy AEDs, establish an efficient EMS system, provide access to evidence-based post-cardiac arrest care, and as per what I coined as ART program, create awareness, do more research on this, and teach and train lay public, and thereby we can increase the 3 A's, that is, we can make it more awareness, the affordable, accessible, and accountable system of cardiac arrest systems of care. Ultimately, what I mean to say is, we should have a proper goal to increase the survival rate from out-of-hospital cardiac arrest in India from the existing not even 1% to more than 10% worldwide. Even if it is 0, we have to start from where we are. And IMA, I think, is the best organization in the country, constituting members from different specialties and subspecialties, where IMA leadership and IMA members can create awareness, the advocacy, and increase awareness so that the systems of care of resuscitation are improved, and thereby awareness, the improved survival rate from OHCA in the country. So we need to go together to increase the survival rate. Ultimately, last slide, I thought the Hindu mythology, there is a Mahamrutyunjaya mantra. decoding that to the present day scientific world. Trayambakam yajame sugandim pushtivardhanam urvarakame vandanan nutyo mukshi imamuraat. In this, when to avoid premature death, Markandeya clings to the Shivalinga to escape from the noose of Lord Yama. But in the present day world, to escape from the noose of Yama and prevent premature death and prevent and improve the survivor from out of hospital cardiac arrest, it is the lay rescuers who perform bystander CPR, lay rescuers who apply automated external defibrillator, lay rescuers with this awareness. There is an early recognition of OHCA and the ambulance arrival is fast. The EMS providers, the paramedical personnel, then the post-cardiac arrest management, the staff in the post-cardiac arrest care ICC units, what I call the resuscitation referral center and the resuscitation centers, level 1 and level 2 centers. Ultimately, those staff, both the anesthetists, cardiologists, intensivists, see that there is a proper neuroprognostication, rehabilitation, and we provide a fully recovered subject of OHCA. So these are the updates of out-of-hospital cardiac arrest, how we need to improve the survival of out-of-hospital cardiac arrest in our country and globally also. And I thank once again the IMA leadership and scientific committee for giving me this opportunity to present the Dr. and Mrs. Vemuri Murthy award for oration, and I feel humbled and privileged by giving this oration. Thank you so much.
Hi, I invite Dr. R.C. Srikumar to the dais, please.
Thank you, sir, for that wonderful talk. Actually, one of the factors in neuroprognostication, the patient you do MRI, because many people we don't do MRI, but if you do MRI with the diffuse cortical involvement across the ribbon sign, that is one of the bad prognosis signs we used to see. I'm a neurologist, so I can say we used to see a lot of out-of-hospital cardiac arrest. So thank you for that, your wonderful work as well as your lecture, and I request you to accept this Oration Award.
Thank you so much, Dr. Srinivas Ramaka, for such an insightful and informative and short and crisp session. Now it's time to honor speaker of today's first session, Dr. Srinivas Ramaka, with a very special IMA Dr. and Mrs. Vemuri S. Murthy Annual Oration Award. And to do the honors, let me request Dr. Sulfi Nuhu, Dr. V.G. Pradeep Kumar and Dr. R.C. Srikumar to please do the honors. Thank you so much, sir, and thank you so much, the dignitaries.
We'll go to the next oration.